Hello and welcome to my channel. My name is Peter Abraham. I am a registered nurse with experience in cardiology, med surg, long-term care and rehab, and especially hospice. In this channel, we talk about things related to chronic and terminal illnesses, uh, issues family face such as anticipatory grief and grief, hospice nursing topics, which will be part of today's discussion, as well as book writing, because I'm an avid author writing books specifically to empower and encourage hospice nurses to help caregivers of loved ones who are dealing with various chronic and terminal illnesses, and also for holistic nurses like myself that like to practice from a bigger picture. Before I go into today's topic, which is looking at how either you as a hospice nurse during an admission, or maybe another nurse did the admission and you're now taking over the case, a critical baseline that needs to be established, because what I would like to do in future episodes is deal with some of the very common questions from my fellow hospice nurses. How do I document slow decline? How do I write an IDT note, interdisciplinary team note? How do I document this versus that? So, in order to go over those types of discussions, we need a very sound baseline to be established. So, if items like this interest you, please do like below, subscribe, comment. A lot of times, my book writing as well as my videos are based on input that I've been getting from my colleagues and those who are watching and consuming what I'm producing. Um, so, before I go on for today's topic, in all previous episodes, like in this one, I like to go over areas of gratitude. And I would like to actually encourage each and every one of you taking the time out of your day to watch and to listen, to ask yourself the very critical question, what am I grateful for? That's something I encourage you to ask daily and to look for positive reasons. Please find ways to look at things in a positive light. And so, areas that I'm grateful for since Friday's publication, uh, I'm grateful that yesterday my wife and I got partway through. We ordered 6 cubic yards. Oh my word, we weren't sure how much that would be, but it was a large volume, 6 cubic yards of topsoil and compost mixed together and delivered to our driveway. And we were able to take multiple buckets of that to fill 2 out of 4 raised beds so that we could start planting a vegetable garden here in Kentucky. And my wife actually did some of the preliminary planting, some peas, some spinach, and some lettuce. So we have that going in 1 out of our 4 beds. And then I'm hoping later on today to just get out there while it's still nice out here in central Kentucky to work on getting our 3rd bed at least partially filled. And then, as weather permitting, we'll get the 4th bed filled up too. But I'm grateful that we're working through that. And when we talk about self-care, this is a way for self-care. I write books. I'm an introvert. I read books. I've been taking time to read the first book of the Wheel of Time series. And you need to do a variety of tasks, my opinion only, as part of self care. So I believe self care involves exercise. So I am sore all over from that. I'm also grateful that I encouraged Rebecca, who took my advice to go see her father this past weekend. She saw him on Sunday. He opened his eyes briefly, and she got to spend time with him. And please keep Rebecca in prayer, because he did pass away overnight between Sunday evening and Monday morning. But I'm grateful for that Rebecca broke through and made that visit. She got to see her father one last time. And so I'm grateful for each and every one of you taking the time out to watch these videos. I'm grateful for those who have been buying my books. So part of what I'm going to be going over today, moving on to the discussion, is the importance to establish a baseline. So part of what I'll be showing you briefly in a few moments is from chapter 2 of the book Mastering Hospice Eligibility. I'm so glad I took the time to write this book. I'm so glad for Dr. Andy, who has promoted this book on LinkedIn, going over why he believes that medical directors as well as hospice nurses should have this book. I do believe, I am biased, I do believe this is a complete replacement for the quick flips. No, it's not as fast to quick flip through, but it gives a foundation for admitting any patient that is eligible, even if they don't have an LCD. So an LCD is wonderful if you have a local coverage determination to utilize. But what if you don't have one? This book goes over the critical thinking of how do you admit that patient, how do you present the case to the medical director to get that certificate of terminal illness. And so chapter 2, I'm going to go over briefly through a walkthrough on that. And I'm also going to go over the brain sheets that I use for admission and routine visits. So let me go over chapter 2. This is from chapter 2 of Mastering Hospice Eligibility, an essential guide for RNs and clinical managers. To me, this is one of the foundational pieces of eligibility, is understanding the patient, caregiver, medical power of attorney, family perspective of why hospice, why now. It is so important to do that baseline interview, reviewing what led the person to consider hospice in the very first place. So I'll give you a moment on these 2 pages. Then as you're asking the family, the caregiver, the patient, why hospice, why now, what led you to hospice, have your notepad ready and take notes on dates, any times mentioned, any approximations given for how has the patient condition declined over the past 2 weeks. What we're going to be looking at is what changed in the last 2 weeks, what changed in the last 30, 60, 90 days, and even going out the last 6 months in order to get a proper baseline. Part of this is looking over what types of hospitalizations, ER visits, urgent care visits have occurred during those time frames. Any decrease in tolerance for physical activity, any changes in cognition. And here, once you've gone out at least 3 to 6 months, now you don't, some patients, when you go to see them, like they're dying, you don't have to go out this far. But if you're there, gee, I just don't know, I'm not sure, you do want to do that full questionnaire. You're going to get a very rough draft of a prognosis going on. How often have these downward changes been taking place? If there's been one change every 4 to 6, every 4 to 8 weeks, we're looking at 6 months. But if there have been every changes every minute to every hour, then you're looking at less than 24 hours. So you're coming up with a draft prognosis to help guide the family along. You're also taking into account how often they've been sleeping, trigger words that can really look like I need to dig deeper. If you hear these words like they've been sleeping all day, or a very significant decrease in intake, uh, pain all over, you can't even, like you just approach them to touch them and they're guarding already. Those are very critical symptoms to be aware of. There's always that elephant in the room, and this is especially true if this is the post-admission visit. I still remember my patient who turned out to be FAST4. When I went to go see them, the admitting nurse put them on a FAST7A. And to me, there were red flags, like the care plan only had a hospice aide for companionship only. So I needed to then go through what I would have done if I was admitting the patient. Tell me more. Why did you consider hospice? What types of changes have taken place? And in this particular case, the patient was not appropriate to be on hospice, and I had to work with our team to get them off. But that's just a short preview of this already published work, but it is going to be leading into other videos that we're going to be doing. How do I document slow change of a condition? How do I document this for IDT, and so on? Now, that was just under a 5-minute segment, but I cannot stress enough that when you do an admission, or let's say somebody else did the admission and you're doing the post-admission visit, or maybe that's done and you're thrown in the middle of it. Your very first meeting with the patient is to do a very comprehensive assessment. The very first time you lay eyes, oh my word, sorry, these are live, unedited. But the very first time you see the patient, this should be an extremely thorough visit. When you're planning this out, please allow for time, not only to do the physical assessment, but to me, what is just as critical, if not more, is to establish that baseline of why hospice, why now. And I want to advise caution right here and right now. The admitting nurse answered all of those questions. They did the why hospice, why now. They did the windows of time. Please do this yourself. If you're case managing, this is your patient, your responsibility. Take that responsibility seriously. And I'm not saying you're not, but take that time the first time you see them to go through and do a comprehensive assessment. And that should go through, if the patient's cognitively able, you're going to be asking them the questions, why hospice, why now, or the caregiver or the family member. I've had cases where it's a facility patient, they have dementia, and facility patient there, the nurses there can't be bothered worth anything. It's like pulling teeth just to get an updated med list. Call the family. I'm seeing this person for the first time. You might have answered this before, but what led you to hospice? You mind walking me through the 2-week picture before they came on to hospice? Do you mind going back another 2 weeks before that? And you're just walking them back patiently and slowly, looking at what was this picture of decline? And that's going to give you what their baseline is. And part of that importance is either you're going to get a picture of rapid decline, and maybe you need to be asking yourself, do I need to make another visit tomorrow? Do I need to plan a PRN visit for tomorrow? I'm not saying change the schedule yet. Part of the art of hospice visit planning, which I do have a book on, is knowing when to change the schedule and when to I'm going to just throw in a PRN for tomorrow. And but if you're getting that picture, it's a whirlwind. This is a rapid decline. If you're getting a picture that this was a moderate changes moving along, these are going to give you pictures of what to expect for future visits, and give you time before you're in that visit to say, okay, I'm going to have a patient that this is going to go slow moving. I need to pay careful attention to X, Y, Z. So you do make your life easier if you invest the time up front. So if you invest the time up front, you can make your life so much easier. So by going through these questions. So in a moment here, I'm going to walk you through 2 different brain sheets. One's going to be an admission sheet, and one's going to be a routine visit sheet. I'm going to show you these back to back. And a lot of times that second video, which is going to be more um, formatted from a tabular perspective, sometimes I'll use that on the admission just because it's so formatted so well. And you'll see, and granted, I'm biased because I created these sheets. But let me walk you through that now. This is an example of a brain sheet that I would often use for admissions. It would allow me to keep track of their date of birth, their age, their biological gender, height and weight, so we can get BMI. Terminal DX would be the primary. Oftentimes during admission, I would put the suspected one that we're going to be used. Um, the PCP name, this is not the medical director, that's typically the doctor that's the attending that's following. Any known allergies, past medical history, whether they're a veteran, what branch, or did they see active duty. Then during the admissions, I'm going over as part of my assessment, what ADLs are they capable of doing completely on their own, or to what level they need help. Like, are they complete care? Do they need help dressing? Approximate food intake, preferably in calories or percentage of meals, where you're kind of ballparking. If you're just doing percentage of the meals, that can be very misleading because 75% of 1,000 calories versus 75% of 200 calories, where you don't know the calories, what good is percentages? Sleeping versus napping, your area for your vital signs, MUAC is that measurement, typically around the right arm. Do be consistent that it is the same limb every time. If there is liver involvement, the ascites girth. Then your head to toe area. Don't forget last bowel movement, because I've had cases for patients coming out of the hospital where maybe they didn't have a bowel movement for 2 weeks, and you would have thought the hospital staff would have treated that, but they didn't. Nausea, vomiting, what does their skin look like? What level of mobility do they have? What equipment needs in terms of planning both now and down in the future. Active medications, and part of this, remember, oxygen is a medication that is commonly forgotten. I've forgotten it at times, which is part of why I'm doing that, a reminder now. Also include the comfort kit meds. These are what you would need to be entering in the hospice MAR, depending on what system that you're using. But when you are doing an admission or post-admission visit, or your first time seeing the patient, please have them get out all their medications again and ask to go through their medicine cabinet. Do you use this? Do you use that? I've had cases where people forget about medications that they might use occasionally. You need to have that in the hospice MAR, especially for your triage nurses that are getting called out in the middle of the night. You need to know what they have access to. Then when you're doing the admission, what's your baseline plan for how often the hospice nurse or LPN or RN will be visiting, how often the home health attendant CNA will be visiting, do they need volunteers? And then I would often flip this page over, and that's where I would be writing down, why hospice, why now? Tell me about the last 2 weeks. Has it been a whirlwind for you? Tell me about the last 30 days, 60 days, 90 days, going out to the 6-month mark, to give me an idea of how frequently have there been moderate to major downward declines, to give me a clue for a draft prognosis that we would be looking at, and to help me to know what do I need to keep an eye out as we're going down the road. And this is an example of a brain sheet that I would use for routine visits, and sometimes I might actually use this as part of an admission visit. Patient name, their age, their gender, primary diagnosis. If I had cases where there was strong involvement from related or comorbid diagnoses, I would list that underneath the primary. The date of the visit, space for your vital signs, New York Heart Failure Scale, height, weight, so I can get a BMI calculation, the MUAC, or MAC for short, powder performance. Sometimes this would be the KPS. I do a slash KPS. Your cardiology assessment, including any edema, pulmonary assessment, your neurological assessment. If they have, keeping in mind the Alzheimer's FAST scale is best used for Alzheimer's only, but it can be used as a frame of reference, in my opinion and experience, for any type of dementia. Just use it consistently. Consistency is the key. Your psychological part of the assessment, this would be disoriented by 1, 2, 3, and so on, and any other notes. GI, GU, along with just any type of dysphagia, what type of diet they're on, their skin assessment, their pain assessment. This is where I make notes for any medication refills and calls to pharmacy. I am a firm believer of doing everything in the visit when possible. So I'd actually be making calls to the pharmacy when I was in the visit unless it was inappropriate. If I had to do counts on medications like narcotics, that would be in this portion of the brain sheet. Any new medication orders obtained by physicians during calls would be put over here. Any changes of conditions and notes I'd have here. And then I'd have a checkbox. Oh, I called the POA. Let's say I'm at a facility. I made a call to the POA. I did a hospice care coordination note. I reconciled the medications. The next line, if it's an NPPA, that's mainly for admissions. Did I get the attending certificate of terminal illness? And if there was a change of primary diagnosis, did I get the appropriate change order? I'm a big person as it relates to checklists and reminders. And with this page, I could easily turn it over and take notes on the back. Okay, so thank you for watching all of that. My goal for this video again is to prepare you for future videos I want to do down the road, to go through portions of this book. How do I document when they are declining slowly, but you know that they're still eligible? If you believe in your nursing gut, you need to learn to trust your nursing judgment. I know this patient is still eligible, but oh my, the past 2 weeks, what do I have? So by establishing a very sound baseline, that's going to help you and help me to help you answer those questions down the road. So if you have any questions, please ask in the comments below. Please shoot me an email, Peter at the number 2, not spelled out, literally 2, abraham.com. Shoot me an email. If you're on Facebook message me. If you do Facebook message me and we're not friends, sometimes that comes through as spam. I do check maybe once or twice a week, maybe every other week. Are there any message requests out there? So please be patient if you go down that route. I don't mind helping. Part of me publishing these videos is I want to help my fellow nurses bloom and grow. You matter, and what you are doing out there matters. So, and if you like what you're seeing, subscribe. Thank you so much for your time, and God bless.